This conference will now be recorded.
Good morning, everyone. Today, the topic of discussion is SIADH. So, can anyone tell me the full form of SIADH? Um, what is SIADH? So, anyone who can tell the full form? So, SIADH is the syndrome of inappropriate secretion of the antidiuretic hormone. Okay, antidiuretic hormone is also called as vasopressin. We'll talk about today. The topic is syndrome of inappropriate secretion. So we'll discuss what is syndrome of inappropriate, what is inappropriate secretion. Okay. Uh, so so what is SIADH? It is a disorder of impaired water excretion caused by the inability to suppress the secretion of antidiuretic hormone. So what this means is there is impaired what does the ADH hormone do? So what does antidiuretic hormone means? So it is the opposite of diuresis. So it inhibits the excretion of water. So it is antidiuretic. And so the water and the sodium is reabsorbed and is present in the and it is trapped in the circulation. So the ADH hormone the uh, prevents the excretion of water. So in a uh, so that's the function of the ADH hormone. So it's in the name itself, antidiuretic hormone. So what does the disorder mean? It means the ADH hormone is the body is unable to suppress the secretion of ADH. That means the ADH will not be suppressed, and this leads to uh, retention of water. Okay, impaired water excretion. The water is unable to go out from the body. So that is the SIADH. So there is inappropriate continued secretion or action of ADH despite normal or increased plasma volume, and it results in impaired water excretion and subsequently hyponatremia and hypoosmolality. So last class we have discussed one of the most important uh, emergencies we see in the casualty, that is hypoglycemia. Okay, so hyponatremia, the important manifestation of SIADH is hyponatremia, which is also an emergency. Okay, it can present as acute emergency, or it can be present as a chronic, but generally these patients generally present to the casualty. We'll discuss the signs and symptoms of hyponatremia later. um, so there is so what does the term inappropriate means is uh, the ADH is being secreted even without the need of it. So ADH is not required in the setting. So in our body, currently the ADH secretion, increased ADH secretion is not required by the body, but it is being secreted. So that causes uh, increased plasma volume. That means it is not required by the for the body. This increased plasma volume is not required. So what happens if there is increased plasma volume? ADH will be suppressed, but the ADH is not being suppressed. So that causes SIADH. So what's the physiology? First we learn about the physiology, then we can properly understand the meaning of SIADH. So arginine vasopressin, ADH is also called as AVP. So we call it as this vasopressin. It is a natural occurring antidiuretic hormone in humans. It is synthesized in the anterior hypothalamus, and it is transported to the posterior pituitary where it is secreted. So what are the stimulus for the secretion of AVP? Hyperosmolality. So the normal osmolality of the body is from 245 to 280. Okay. So when the osmolality, that means what does osmolality means? When the solute levels are the solute levels in the body, not the solute, sorry, solvent. The solvent levels are in the body is determines the osmolality of in the body. So when there is hyperosmolality, that means there is, when in case of hyperosmolality, there is decreased solvent. In the case, in the body, the solvent is the water. So when there is decreased water and there is increased solute means NaCl, sodium and chloride. So these are so when the concentration of the salt levels or sodium or chloride, when these levels are increased in the body, and the solvent levels, that is the water, is decreased, then we term it as hyperosmolality. So this is the stimulus, one of the factor for the increased secretion of ADH. So how does the hyperosmolality being detected? It is sensed by the osmoreceptors in the hypothalamus. So there is a direct feedback loop. When there is when the hypothalamus senses that there is hyperosmolality in the body, it secretes the ADH and it gets transported to the posterior pituitary. So that is one. The second one is the circulating volume depletion. Okay, this is different than this. In this, the total volume is decreased, not just water. Even the solute levels are also decreased, like in hemorrhage. Okay, when there is massive hemorrhage, the total volume will be decreased, right? So that is one. Or else in shock also there is a diffuse vasodilatation. So the overall circulation will be decreased. So this circulating volume depletion is sensed by the baroreceptors in the carotid sinus. Okay, carotid sinus, aortic arch, and left atrium. So these also again these carotid baroreceptors give feedback to the hypothalamus. So and so then the after sensing these hyperosmolality and decrease in the volume, the ADH receptors are stimulated. The ADH is secreted. Then they act on the ADH receptors. And where are they present? So there are two types, V1 and V2. Okay, and V1 is again divided into V1A and V1B. So there are three types of ADH receptors. V1A is it stimulates vasoconstriction. V1B, it stimulates ACTH secretion. That is the ACTH is adrenocortic corticotropic hormone. So this acts on the adrenals to synthesize the adrenal cortisol and epinephrine, norepinephrine. Okay, and it also stimulates the secretion of aldosterone. Sorry, no, just cortisol and epinephrine, norepinephrine. Whereas V2 channels, these are the most important receptors. What they do is the insertion of water channel aquaporin 2 in the luminal membrane of the collecting duct, thus making it more permeable to water. So normally when plasma osmolality falls below 275 milliosmolar per kg, AVP secretion stops. So this causes increases water excretion, which leads to dilute urine with an osmolality of 40 to 100. But when the osmolality rises, AVP secretion increases. Okay, so this increase in water reabsorption and increase in plasma osmolality, it can be up to 1400. So the basic physiology of ADH is, first, there is a volume decrease in the body. It then it acts on the hypothalamus. Hypothalamus releases the ADH, and ADH is released in the body. So it what does it do? The ADH, it acts on the kidney. Where in the kidney? In the collecting duct. Okay. So in the it's in the collecting duct. What does the collecting duct do? Normally the water and sodium both are 65% is reabsorbed in the proximal convoluted tubule. So that is a mandatory reabsorption. That is the reabsorption will be done whether irrespective of the volume of water in the body. Then it goes to the thin ascending loop and thick ascending loop. In the thin ascending loop also there will be reabsorption of the water and sodium, and then it goes into the distal convoluted tubule. There also there will be mandatory reabsorption of the water and sodium. But then it goes into the collecting duct, where there is selective, it is not non-mandatory, there will be non-mandatory uh, reabsorption of the water and sodium. What does this means is, if the volume of the water and sodium in the body is normal, that means it is high, this ADH does not act on the collecting duct. ADH secretion will be decreased and it does not act on the collecting duct because there is increased water and sodium in the body. The water and sodium will, the collecting duct will not reabsorb. Okay, there will not be reabsorption in the collecting duct, and the water and sodium will be excreted in the urine. So so this AVP secretion stops, there is increased water excretion in the collecting duct. Okay, so in the collecting duct, and it leads to a dilute urine because there is increased water. So it will be excreted. So that's the aim of the body. It wants the water to be gone from the body. So it makes the urine dilute and they will be excreted. So when the reverse happens, that means when the osmolality rises, the AVP secretion will be there, right? So what it does me is it acts on the collecting duct. It makes the collecting duct more permeable to water. Okay. Uh, there will be increased reabsorption of the water and sodium. By how the mechanism is, it causes the insertion of the water channel aquaporin 2. Okay, through this aquaporin 2 channel, the sodium is reabsorbed and there will be increased secretion of potassium into the collecting duct. So that what makes the collecting duct permeable. So this aquaporin 2 channel is very important for you later in the MCQs and all. Uh, so it is stimulated by the ADH. So you have to remember it. Okay. And that causes, so decreased water will be excreted from the body. So and it causes increase in the urine osmolality. There is increase in water reabsorption and increase in urine osmolality because the amount of water will be decreased. When there is decreased amount of water anyway, it causes an increase in the osmolality. So that's why urine osmolality is increased. Okay. So this is the basic physiology and mechanism of the ADH. You have to, if we understand this basic mechanism, then we can move on to the pathophysiology. Then only we can understand it. So what's the pathogenesis? So just we have discussed the release of ADH is inhibited. So when there is a decrease in the plasma osmolality, there is no need for the ADH to be released. The body does not need the function of the ADH because the plasma osmolality is decreased or normal, and we don't need more water in the body when the osmolality is decreased. So when there is decreased osmolality, what does it mean? There is increased water. But in the SIADH, the release of ADH is not inhibited. So it's not inhibited by the reduction in plasma osmolality. The ADH keeps secreting. That's why it's called as inappropriate. That means even when there is no need for the release of the secretion of the ADH, it will get secreted. The non-physiological secretion of AVP results in enhanced water reabsorption, leading to dilutional hyponatremia. I'll tell you. So the AVP results in the it actually results in both the reabsorption of the water and sodium. But in SIADH, what happens means there is this hyponatremia does not occur as a result of decrease in sodium. Sodium levels are normal. They do not get changed. But the problem is the water gets increased. So what happens when we take a glass, we add 1 spoon of salt and a half a glass of water. Okay, the amount of salt in that will be 1 spoon only. Okay, when we measure it, the value will be some like 100 or something, the amount of sodium. But if we dilute it and we make the half glass full, then the concentration of the sodium gets decreased. So what changes is not the amount of sodium, but the concentration of sodium is decreased. So that's what is called as dilutional hyponatremia. there is transient expansion of the extracellular fluid volume. So the ECF will be increased. That means the water in the tissues and everything in the cells tissues will be increasing. The volume receptors are activated and natriuretic peptides are secreted, which causes natriuresis and some degree of accompanying kaliuresis. Kaliuresis means excretion of potassium. Natriuresis means excretion of water and sodium. So, since the ADH is being secreted inappropriately, the volume receptors will be activated, which are present in the not the osmoreceptors, volume receptors in the carotid, sinus, arch of aorta. These will be activated. But the osmoreceptors, the fault is basically wait 1 minute. The problem is here. The hypothalamus is not able to detect the hyperosmolarity. The osmoreceptors are not able to detect the changes in the osmolarity. But these circulating volume depletion, these baroreceptors are working fine. So they will notice the increasing volume, but the osmolarity will not be detected. That's when there will be natriuresis. Okay. That the natriuretic peptides A and P, B and P, these will be secreted and they cause excretion of water and sodium. But it's not enough to compensate the increased ADH. So what are the manifestations? As we have discussed, hyponatremia. This is the first and foremost symptom, not symptom, condition we will see in SIADH, hyponatremia, and inappropriately elevated urine osmolality. Why does we call it as again inappropriately elevated? When there is actually the volume of the water in the body is normal or even high. Okay, so what we have discussed, when the volume is high, there should be dilution, decreased urine osmolality, and there should be diluted urine. But there is elevated urine osmolality, which is a paradox. Okay, so that's why it's called as inappropriately elevated, greater than 100. And there will be decreased serum osmolality. When there is decreased serum osmolality, there should be decreased urine osmolality also, because the water is being excreted. So this is decreased, this is elevated. That's the problem. So this is the actual definition of SIADH. There should be hyponatremia, inappropriately elevated urine osmolality, and decreased serum osmolality. These three criteria should be satisfied in a euvolemic patient. What is euvolemic? We have three types of volemia in the body: hypo, eu, and hyper. Okay, when there is decreased volume or else water, anything, all the solutes and solvents are decreased in the body, like in we have discussed previously, shock, massive hemorrhage, or in case of severe diarrhea or vomiting, these are called as hypovolemic states. Okay, whereas euvolemia is the amount of water in the body is normal, there is nothing wrong. Whereas hypervolemia is seen we see it in nephrotic syndrome, like edematous states. Any edematous states are called as hypervolemia. Okay, so in a euvolemic patient, in the setting of normal cardiac, renal, adrenal, hepatic, and thyroid function, because any dysfunction in any of this in any of these disorders can cause also hyponatremia. Okay, and in the absence of diuretic therapy. Diuretics are one of the mainly thiazide diuretics, loop diuretics. These are one of the major cause of hyponatremia. So in the absence of diuretic therapy and in absence of other factors known to stimulate ADH secretion, such as hypotension, severe pain, nausea, and stress. ADH is also stimulated by these conditions: pain, nausea, stress. So everything should be normal. So that's the SIADH. Even when everything is normal, there is still inappropriate secretion of ADH. These three conditions can also be seen in all these conditions: diuretic therapy, cardiac disorder, cardiac failure, renal failure, adrenal failure, or adrenal excessive Cushing's, hepatic, we see edema like ascites, even in thyroid mixed edema, hypothyroidism. So these all should be absent, but still there is inappropriate secretion. So that is called as the SIADH. So what is the etiology? So why does SIADH occur? There are many disorders which can cause SIADH. So one some of the disorders are malignant diseases. Any malignancy can cause SIADH. So the most common malignancy which causes the SIADH is the lung carcinoma. That too, small cell carcinoma is the most common malignancy, and many varieties are present. Like oropharynx, GI, genitourinary. So all these can cause the SIADH. And another even lung disorders can cause SIADH. It is also seen in like bacterial infections, any infection, cystic fibrosis. It is also another cause. Respiratory failure, asthma, and uh, any disorder of the CNS, meningitis, so like same infection, bleeding, mass, like SAH, because there is the ADH secretion is uh, uh, it take place in the CNS, right, in the hypothalamus. So any disorder will cause this of the CNS will cause hyponatremia, SADH, especially brain tumors. Mm. Next, drugs. There are so we have to exclude the drugs other than the diuretics. So one of the most common drugs which cause are antipsychotic drugs like SSRIs and TCS. These are the main drugs we use for the psychiatric patients, right? So, but these are also one of the major side effect is the SIADH. So they just stimulate the release of AVP, ADH. So anti-cancer drugs, antipsychotic, antidepressant drugs, even NSAIDs, drugs like narcotics and MDMA, ecstasy. These all cause the um, and and AVP analogs. So these drugs are the AVP analog. So when we give from outside, like for the treatment of hypernatremia or something, desmopressin, oxytocin, these will also cause the hypernatremia. And others are the general, like we have discussed previously, pain, nausea, stress, exercise. Uh, so and there's a hereditary condition. So these are all the causes. So how does the patient present? So now we will see the hyponatremia signs and symptoms. How to recognize the patient with hyponatremia. So hyponatremia, we can divide it into acute and chronic. Okay, so both the type of patients can be seen. So how does the acute and chronic will present? Both will be different. Okay, the most important difference is that the magnitude and rate of development. Okay, so acute hyponatremia, they present as an emergency. The patient will present as drowsy or comatose. So in one of the DD we have to keep in mind is hyponatremia. Okay, for comatose patients. So we have to check the electrolytes, and if there is decrease in sodium, we have to correct it, because hyponatremia patients can go into coma very easily. That too acute. That means the decline in the sodium should be very steep. Whereas in chronic, the patient just becomes there can also be not be any symptoms or signs. In chronic hyponatremia, the patient may just be sleeping more, excessive sleeping will be there, or just the patient will be feeling lethargic, restless. That's it. There will not be much dramatic symptoms or signs in chronic cases. So acute hyponatremia, we can see it in the emergency. Um, so signs and symptoms of acute hyponatremia do not precisely correlate with severity or acuity of the hyponatremia. Some patients with profound hyponatremia may be relatively asymptomatic. Just as I said, if it is chronic, the patient can also be asymptomatic. Okay, the patient will normally the sodium values are 135 to 145, right? So we sometimes if it is acute, a patient with just 128 125 sodium will be present as severe drowsiness, whereas a patient with chronic hyponatremia patient with a value of 110 100 even 100 95 also can be seen. They will be asymptomatic or just relatively drowsy or just lethargic, that's it. Okay, so the rate of development is very important. When serum sodium is less than 125, anorexia, nausea. Nausea is also one of the main symptom of hyponatremia. We should, in any case with in an elderly patient with nausea, we have to consider hyponatremia, especially chronic. Anorexia, malaise, these will occur. Whereas further decrease can cause headache, muscle cramps, irritability, drowsiness, confusion, weakness, seizures. Even seizures is also an important manifestation of hyponatremia, and coma. Uh, Coming to the physical examination, the patient should be, as we have discussed, euvolemic and normotensive. The BP should be normal, and there should be no edema or any dehydration like dry mucous membranes or reduced skin turgor. So these should be absent. And if there is severe or rapid onset hyponatremia, we can have delirium, muscle weakness, myoclonus, hyporeflexia. So these are all the signs. Okay, we examine it. Dysarthria, Kinestokes respiration, seizures, and coma. So how do we work up? One second. So this is the algorithm for hyponatremia. So this is what we should evaluate when a patient with hyponatremia presents to us. Uh, First, we have to assess the volume status. In the hypovolemia, so we have already seen that there is hypovolemia, euvolemia, and hypervolemia. What does hypovolemia means? There will be hyponatremia, and there will be decreased body water and decreased body sodium. Both will be decreased, but the sodium is more decreased than water. So that's where when hypovolemic hyponatremia occurs. Whereas in euvolemia, the sodium levels are normal, but the water is increased. That's it. There is no change in the sodium, but only water is increased. Whereas in hypervolemia, uh, both water and sodium are increased. So, but how does hyponatremia occurs? The amount of water increased is much more greater than sodium, and this also causes dilutional hyponatremia. So this is an example of dilutional hyponatremia. It's not just that the sodium is decreased, but that the water is much more increased. Okay. Um, According to the urine sodium, we measure we differentiate the causes. Okay, in some of the examples of hypovolemic hyponatremia are excessive diuretics. So these are mineral like adrenal insufficiency. One of the manifestations of adrenal insufficiency is hyponatremia because both the sodium and water are being lost. Um, and extrarenal causes, these are the vomiting, diarrhea. There will be severe dehydration, right, in that. All the sodium and water both are lost. The burn patient, pancreatitis patient, trauma, third like in severe hemorrhage, third spacing of fluid. So these are all the causes of hypovolemic hyponatremia. Whereas in euvolemic hyponatremia, other than so the first cause we have to uh, we have discussed, what's the cause we know is SIADH, right? But before we label a case of SIADH, we have already discussed that we should exclude the other causes. SIADH is a diagnosis of exclusion. Okay, after excluding everything, then only we have to keep a diagnosis. So in euvolemic hyponatremia, glucocorticoid deficiency, hypothyroidism, stress, drugs, everything should be excluded. Then only we should come to this. Whereas in hypervolemia, renal failure, we have already discussed, right? Renal failure, nephrotic syndrome, cirrhosis, cardiac failure. So these are the causes of hypervolemic. So when we do investigations, there will be serum sodium. It will be less than 135 because the normal values are 135 to 145. Less than 135 is present in hyponatremia. So potassium is not much changed. We see the urinary excretion, how much sodium is being excreted to differentiate it between into renal or non-renal, extra-renal. And another important one is the urine osmolality. So we have discussed, right? Inappropriately elevated, greater than 100 should be present. Urea will be decreased, uric acid will be decreased. So these are another two features of SIADH. And we do imaging like chest X-ray, CT, and MRI for any tumors, any infections, pulmonary, bronchiectasis, etc., or any CT, MRI of brain. Okay. So how do we manage? So first, any case of hyponatremia, like euvolemic hyponatremia, especially SIADH, almost the treatment is same because we have to raise the serum sodium. That's the um, uh, that's the cause that is causing all the signs and symptoms. First, for the SIADH, we have to treat the underlying cause. That's the main mm, uh, that's the main cornerstone of the treatment. We have to treat the underlying cause. Without treating the underlying cause, we cannot treat the SIADH. Okay, initial therapy is to raise the serum sodium. So if there is adrenal insufficiency, we have to supplement the cortisol from outside, or thyroid, we have to treat the infection, or the if drugs are involved, we have to stop it. If there is a carcinoma, we have to start chemo or radiotherapy, like that. So what do we do in the emergency? Um, we have to correct the hyponatremia. Okay, um, but correction of hyponatremia is a very double-edged sword. Uh, if we correct it slowly, actually the hyponatremia should be corrected slowly only. It should be very slow. Not so much slow that there is no change in the patient, but it should be relatively slow. We can treat slowly, but we can't treat it fastly because aggressive treatment increases the risk of inducing central pontine myelinolysis, which leads to the paralysis of all the four limbs. Okay, because pons is the center, it causes dysarthria uh, dysphagia, and quadriparesis. So we have to prevent it. It is very important in case of hyponatremia. Okay, we shouldn't treat it aggressively. If there is aggressive management, it should be done only in case of, like, if the patient has ongoing seizures or is in stupor, coma, respiratory arrest. Only in these cases we have to go somewhat aggressively. Afterwards we have to decrease it. Correction of hyponatremia at a rate that does not cause neurological symptoms. So how much we have to correct? We should raise the serum levels by 0.5 to 1 milliequivalent per hour, and not more than 10 to 12 in the first 24 hours. Okay, so in 24 hours we should correct only 10 to 12. We have to serially monitor the sodium, like we do it generally 6th hourly or 8th hourly. Okay, we adjust the sodium by that. So how do we correct? So what do we use to correct it? If the hyponatremia is very low, like very like 130, 128, like that, we generally typically use the normal saline which we get in the casualty. But if it is acute and we have to correct it, we use 3% hypertonic saline. So 3% NaCl. We use it to correct it because it is very tonic, like potent. It just has a small volume, contains very large amount of salt. So there will not be, we won't be giving excessive water, because the problem in SIDH only, there is excessive fluid in the body. So first we have to restrict the uh, fluid. Okay, that's what should we have to restrict the water ingestion into the body. So that's why I use 3% hypertonic saline. Other treatment we use is furosemide, because it increases free water excretion, because free water is increased, and it limits treatment induced volume expansion. Since if we have to supplement NS from outside, furosemide makes the water go away from the body. So water restriction is the main. Next is hypertonic saline. Sometimes even water restriction is enough to treat a patient of hyponatremia. So that is how important it is to water restriction. And furosemide. It may lead to a faster rate of correction of serum sodium. Requires frequent checking, as I have said, 6th hourly or 8th hourly sodium checking of the serum sodium is required. So what is acute hyponatremia? When it occurs less than 48 hours when the patient presents to us, and they have symptoms like confusion, disorientation, nausea, vomiting, etc. So the treatment options are 3% NS, loop diuretics with saline, we have already discussed, water restriction, and vasopressin 2 receptor antagonists. We will see about this. These are Vaptans. When there is moderate neurological symptoms, we use 3% hypertonic saline. Less severe symptoms or no symptoms, we just use water restriction is enough. And sometimes Vaptans, vasopressin 2 receptor antagonists. So water restriction, it is a mainstay of treatment. Okay, so this is the first thing we should do for the treatment is we have to stop everything. The fluid should be stopped. Okay, in case of SIADH, and it depends on prior water intake, expected ongoing fluid losses, and degree of hyponatremia. We have to restrict to just the patient should be allowed only half liter to 1.5 liter per day, 500 to 1500 ml. In case of subarachnoid hemorrhage, fluid restriction reduces BP and promotes cerebral vasospasm and infarction. Instead of treating with water restriction, we have to treat with 3% NS, because water restriction is dangerous in case of SIH. So what are these vasopressin receptor antagonists? So they inhibit the V2 receptor. We have already seen, right? V2 receptors are present in the collecting duct, which they cause the ADH hormone acts there. So we block the V2 receptor, and it reduces the number of aquaporin 2 channels through which the water goes is reabsorbed into the body. They reduce the number and reduce its water permeability, and water will be excreted. So these are called as Vaptans. What are the Vaptans? Conivaptan and tolvaptan. Conivaptan is a parenteral. Okay, this is a parenteral. It also acts on V1A and V2 receptor. It blocks both these receptors. 20 mg is loading dose. It should not be used for more than 4 days. Okay. Conivaptan plus 2 liters fluid restriction over 4 days. It increases serum sodium by 6 milliequivalents per liter. What we use in our setting is the tolvaptan, because it is an oral drug. Okay, we start it at 15 mg daily, and it can be titrated up to 60 mg. So it can be adjusted. So this tolvaptan we can give up to 2 to 4 weeks. Okay, but what we have to do is we have to monitor the sodium for every 5 days, and if the sodium is getting corrected, we can withdraw the drug. Where tolvaptan plus fluid restriction, it increases the serum sodium by 8 milliequivalents over 30 days. So conivaptan, it increases very fastly, like in the acute setting, whereas tolvaptan, we can it acts over days, weeks. patient can be discharged in 24 to 48 hours if neurological symptoms have resolved. Okay, if there are no neurological symptoms for the patient, we can just prescribe tolvaptan and tell the patient to have fluid restriction, and that will be enough for the treatment of SIADH. Vaptans, they promote correction of serum sodium, and they produce water excretion without electrolyte excretion. So what Vaptans does is they just excrete the water without disturbing the electrolytes. But one side effect or risk is sometimes they excessively correct the sodium. So all this we have seen for acute hyponatremia. So what do we do for chronic hyponatremia? In that case, we can fluid restriction can be done. Vaptans can be used. And loop diuretics like furosemide, these can be used. Urea, mannitol. Mannitol is a hyperosmotic agent, right? So it helps. And even democyclozine. It is a tetracycline. So what does urea do? It increases urinary loss of water along with urea and decreases free water retention. So free water retention will be decreased. So there will not be much water in the body. It can be given as a powder through IV or gastrointestinal tube. Mannitol also, it is a diuretic, right? So it promotes free water diuresis. So all the diuretics which can all the agents which can excrete the water without excreting the electrolytes can be used for SIADH, because only water is increased in the body, that water should be excreted. So mannitol can be used. Coming to democlocycline, so it is a type of tetracycline. It induces diabetes insipidus in the body. It impairs so what does it do is it acts on the cyclic AMP. Okay, so this cyclic AMP it is not generated. So when there is no cyclic AMP, AVP cannot act on the collecting duct. Okay, so when it does not act on the collecting duct, sodium will water free absorption will be reabsorption will be inhibited, and it will be excreted. Okay, that's it. Any doubts?
No, ma'am.
Huh? Yeah. Anyone having any doubts?
No, ma'am.
No, ma'am.
Okay, thank you.